Okay, let's really get into this. Today on the deep dive, we're tackling a core topic in vascular surgery, Aortoiliac Occlusive Disease, or AIOD.
Right, AIOD. It's a common challenge.
And we've got chapters from Rutherford's vascular surgery here.
Yeah,
The foundational text.
absolutely. The goal is to figure out when and how direct surgical reconstruction comes into play today.
Especially since less invasive treatments have become so common.
Exactly. But, open surgery for AIOD, it's still absolutely vital. We need to explore why.
So we'll trace the history a bit, the pathology, how it presents,
Yeah, how we diagnose it, the specific time surgery is the best call.
and the techniques themselves, the
Mm.
outcomes too.
Right, what the results actually tell us.
It's pretty amazing looking back. John Hunter, late 1700s.
Yeah, recognizing those blockages where the aorta splits.
His dissection work, those specimens in London, they sort of paved the way for Lariche, didn't they?
They really did, foundational stuff.
Yeah.
Then you jump to the mid-20th century, real surgical leaps.
Like Dos Santos' endarterectomy work.
hmm And Wiley extending that to the aortoiliac level. Then synthetic grafts became the thing around 61.
A whole history of innovation there.
Absolutely. And, while endovascular treatments, angioplasty, stentings, they're often the first step now.
For AIOD, yeah.
That classic aorta bifemoral graft, the ABFB, it hasn't disappeared.
It's more for complex cases now.
Ah,
Or failed endo.
pretty much. Reserved for those tougher situations. But here's the thing, it's still considered a gold standard.
Really, even with the bigger surgery involved.
Yeah, patient satisfaction is high and the long-term results. Excellent. Unpacking why that is, that's a big piece of today.
Okay, so let's get down to brass tacks. AIOD. What is it, fundamentally?
So in simple terms, it's atherosclerosis, that plaque buildup.
Where exactly?
In the abdominal aorta, the big artery in your belly, and the iliac arteries that branch off down to your legs.
And it usually starts low down.
Typically, yeah, right at the end of the aorta where the common iliacs begin. Then it can creep up or spread further down.
And how fast it progresses varies.
Hugely. Person to person. Sometimes it can even block the aorta completely.
Wow. But the body can compensate sometimes.
It's quite amazing, actually. It often develops collateral circulation.
Like detours. Natural bypass.
Exactly. A whole network of smaller vessels. And these can often prevent the really bad stuff, like chronic limb-threatening ischemia.
Especially if the main blockage is fairly localized.
Right, if it's just focal AIOD.
So can you describe these main detour routes? Where does the blood go?
Well, the primary ones involve connections from the lumbar arteries in your lower back and the hypogastric arteries in the pelvis.
Okay.
And these link up with vessels like the circumflex iliac, other pelvic branches, and ultimately the femoral and profunda arteries in the thigh.
And if the blockages are really bad?
Then the body gets even more creative. You might see connections between chest wall arteries like the internal mammary and abdominal wall arteries, the inferior epigastric, and even connections between the gut arteries, superior and inferior mesenteric things like the arc of Reelin, the meandering mesenteric artery.
Wow. So surgeons really need to know about these.
Absolutely critical. You have to preserve these collaterals during surgery. You don't want to undo the body's own good work.
Makes perfect sense. So who typically gets AIOD? Is there a profile?
Well, the picture's shifted a bit. A lot of patients today have diffuse disease, multi-level.
Meaning blockages not just in the aorta and the iliacs, but lower down too.
Exactly, femoral popliteal, even further down. But when we see isolated AIOD, just the aorta and iliacs,
Yeah.
those patients tend to be younger, more likely to smoke, have high cholesterol, gender distribution is about equal.
And their life expectancy.
Often normal, interestingly. So isolated AIOD looks a bit different.
Right. So what are the ones with more extensive multi-level disease?
They're usually older, more often have diabetes, hypertension, more likely male.
And probably have plaque elsewhere.
Yeah, very often. Brain arteries, heart, kidneys, gut. And unfortunately, their life expectancy tends to be poorer than average for their age.
And you mentioned a specific aggressive form.
Yes, sometimes called small aortic syndrome or hypoplastic aortic syndrome. It hits young women, heavy smokers,
What does that look like?
narrowed calcified arteries, often a tight spot near the bifurcation. They might lack other risk factors, but the smoking history is usually significant.
And treatment is tricky.
Very. The small vessels don't respond as well to endovascular or even local surgery, especially if they keep smoking.
That really paints a picture of how varied AIOD can be. How does it actually show up for the patient? Symptoms.
It's a spectrum, can be mild claudication.
That leg pain with activity goes away with rest.
Exactly, cramping usually.
Right.
Or it can be much more severe chronic limb-threatening ischemia, CLTI.
And where is the claudication felt with AIOD?
If it's mainly the aortoiliac segment causing the issue, the pain is often in the calf, thigh, hip, or buttock.
And CLTI means?
Usually means blockages at multiple levels, not just AIOD.
Okay. And you said AIOD claudication tends to appear younger?
Yeah, typically younger than claudication from blockages purely lower down in the leg.
Are there other, more specific symptoms linked to AIOD?
Definitely. Erectile dysfunction is common in men, maybe up to 30%, just not enough blood flow through the pudendal arteries.
Right.
And then there's Lariche syndrome. That's the classic triad in men with complete blockage at the end of the aorta.
What does that involve?
Claudication thigh, hip, buttock, muscle wasting in the legs, impotence, and you often can't feel the femoral pulses well in the groin.
And in women. The impact of poor pelvic flow.
That's actually less well understood, an area needing more research.
So, patient comes in with these kinds of issues. How do you nail down the diagnosis?
It really starts with a good history and a thorough physical exam.
Talking and looking.
Yeah. Often, if someone has risk factors, reports claudication, and you feel weak or absent pulses in the groin, AIOD is high on the list.
But you have to rule out other causes.
Absolutely. Hip arthritis can mimic buttock pain, nerve root irritation from the spine, too.
And symptoms can vary quite a bit.
They can. Proximal claudication is most common, but sometimes it's just the calf. And those collateral vessels...
They can mask things.
Right. Pulses might feel okay at rest, then disappear after exercise. Brutes, those whooshing sounds, might only show up after exertion, too.
And need to be careful not to blame the groin arteries for an inflow problem.
Exactly. Sometimes the issue is right there in the common femoral or profunda, not necessarily higher up. Got to differentiate.
Okay, so history and physical are key. What about tests?
Non-invasive hemodynamic tests are crucial. Things like segmental pressures, pulse volume recording.
Like blood pressure cuffs at different leg levels.
Pretty much. They help confirm PAD, locate the blockage, estimate severity. We look for pressure drops.
Like between the arm and thigh.
Yeah. A difference of 20 millimeters of mercury or more systolic suggests significant AI stenosis. Normally, thigh pressure is actually higher than brachial.
But other blockages can interfere.
Right, like a bad SFA blockage. And again, collaterals can sometimes hide a gradient at rest.
So what if the resting tests are borderline but symptoms are bad?
That's where exercise testing comes in. Treadmill test. Very useful.
So history, exam, non-invasive tests, usually enough to diagnose before deciding on treatment.
Generally, yes. That combination gives you a pretty clear picture.
And then for planning how to fix it. Imaging.
Right. That's when we use things like duplex ultrasound, CTA, MRA, sometimes traditional arteriography. Need that detailed roadmap.
Okay, diagnosis covered. Now, the big one. When do you intervene surgically? It sounds like endovascular really shook things up.
Fundamentally, angioplasty and stenting are the go-to now for most AIOD, and renal, subclavian, coronary too.
Even for complex blockages that used to be automatic surgery.
Yeah, even long lesions, the PAS-CD type stuff, we're treating much more complex disease percutaneously now.
So the shift away from open surgery has been huge.
Dramatic. One study showed like an 850% increase in angioplasty stenting for AIOD in the late 90s, while aorta bifemoral bypass went down 16%.
Wow, so when is open surgery the right choice now?
It's generally reserved for when endo fails, or the disease is just too extensive, too complex for wires and balloons.
Meaning the open cases today are often tougher.
Definitely. More likely to need suprarenal clamping, maybe fixing visceral arteries at the same time, dealing with disease above and below, redo surgeries.
But it still has a role for combined aneurysm and iliac occlusive disease.
Yes, though that group might shrink as endovascular aneurysm repair evolves, and things like heavy calcium disease down to the CFA. Not necessarily automatic no for endo anymore.
Covered stents, hybrid procedures help there.
Exactly. But open might be better if AIOD comes back fast after endo, or if the patient has bad kidney disease.
Risk of contrast die.
Right, or the rare times endo causes a dissection or rupture, then open surgery is the bailout.
Okay, that clarifies the current landscape. What about intervening just for claudication, that leg pain?
It's a relative indication. Framingham studies showed claudicants have higher heart risk, but low limb loss risk.
Many stay stable or improve with medical therapy.
The majority, yeah. Risk factor changes, maybe meds. But maybe 20–30% will worsen enough to need something within 5 years.
And some suggest AIOD claudicants might progress more often.
There's some data suggesting that, but because endovascular is safer now, the bar for treating claudication percutaneously is definitely lower.
but medical therapy is still often appropriate.
For many, yes. It's often a benign condition, naturally. You don't want to take unnecessary risks for non-limb-threatening stuff. Collaterals can develop too.
So when is surgical bypass right for just claudication?
For low-risk patients, disabling symptoms and disease really isolated to the aortobifemoral segment, surgery offers excellent long-term patency in that group, safe intervention.
Got it. And then the severe end, chronic limb-threatening ischemia, CLTI.
That's different. High amputation risk without fixing the blood flow.
So rest pain, ulcers, gangrene, those are clear reasons for surgery.
Absolutely. Well-accepted indications. And these patients often have multi-level disease, not just AID.
Meaning you might need to fix inflow and outflow.
Often, yes, especially with tissue loss. Need good pulsostol flow down to the foot for healing. Might need staged or simultaneous procedures.
What about when clots form in the aorta or iliacs and travel down? Ambulate.
Yeah, from ulcerated plaque or a shaggy aorta, that's usually an indication for operative reconstruction too. Even without bad stenosis or claudication, need to stop the emboli.
And finally, patient age or aortic size. How do they factor in?
Well, studies show ABFB works well even in carefully selected elderly patients, so age alone isn't a barrier.
But younger patients are small aortas.
Yeah, there's some data showing lower long-term patency in patients under 50 or with small aortas, so you might be a bit more cautious about early surgery there.
Right, okay, that covers the why and when. Let's move to the how. What are the main surgical options?
Historically, you had AI endarterectomy, aortoiliac bypass, aortobifemoral bypass, ABFB, and then the extra anatomic ones like FemFem or AXFem.
But ABFB is the main one now for open repair.
Generally, yes. It usually offers the best long-term patency, unless the patient is too high risk for that big an operation.
Let's start with endarterectomy then. Sounds like it was big in the early days.
It was the standard in the 50s and 60s for severe AIOD. After Dos Santos's initial work, Wiley extended it up high.
But then prosthetic grafts came along.
Right, in the 60s. And bypass grafting kind of took over, especially for longer segments of disease. Better long-term durability in many cases.
So why might you still consider endarterectomy today?
Well, the main appeal is avoiding prosthetic material. Good if there's infection risk, or to avoid potential late graft issues.
And some argue it's better for younger patients. Or small vessels.
Some advocates feel that way, yeah. And it's thought to be particularly good for erectile dysfunction from proximal hypogastric disease, better pelvic perfusion.
Good results reported for that.
High rates of restored function, yes.
And technically, when does it work best? What kind of blockages?
It's most feasible and durable for focal stenotic lesions, short segments, in large high-flow vessels.
Like the very end of the aorta, or start of the common iliacs.
Exactly. Excellent long-term results there, comparable to bypass. But for long segment disease involving the whole infrarenal aorta, external iliacs, less successful.
And fewer surgeons are doing it now.
Right. Endovascular therapy handles many of those focal lesions now, so fewer patients are candidates, and fewer surgeons get expensive experience with the technique.
Can you briefly explain the technique? How do you peel out the plaque?
It's a direct disobliteration. You find a plane between the plaque, which is in the inner layers, and the outer vessel wall.
Okay.
You carefully separate it, making sure you have a clean endpoint. Often need tacking sutures at the distal end to prevent a flap or clot.
And you do it open, like with an incision in the artery.
Usually, yes. The open method gives direct vision. If the artery's small, you might close it with a patch vein, synthetic, pericardium to avoid narrowing.
But the idea is restoring the native artery lining.
Essentially, yes. Creating a smooth inner surface without leaving foreign material. Beneficial in select cases.
Okay. Now, the workhorse. Aortobifemoral bypass. ABFB. How do you prep the patient?
It's extensive prep. Good 5E access, arterial line for blood pressure monitoring, Foley catheter, pre-op antibiotics are standard.
Keeping the patient warm is important too.
Crucial. Forced air warming helps reduce complications. General anesthesia, often an epidural for post-op pain.
And the exposure, it sounds major. Abdomen and groins.
It is. Usually start with bilateral groin incisions to expose the femoral arteries. Do that before heparin to minimize bleeding.
How far do you dissect in the groin?
Depends on the disease. If you need to work on the profunda, control the SFA and profunda, then create the tunnels.
Retroperitoneal tunnels for the graft limbs.
Right. Blunt dissection behind the inguinal ligament along the external iliac artery path, keeping ureter safe anterior.
Then the aortic exposure. usually through the belly.
Typically transperitoneal, yeah. Midline incision, usually. Move the bowel aside, dissect the retroperitoneum over the aorta up to the left renal vein.
Try to protect the nerves near the bifurcation
Yeah.
for sexual function.
Definitely try to minimize dissection there if possible. If you need higher exposure, up by the renals or even suprarenal, you adjust the dissection. Might need temporary suprarenal control. Then complete the tunnels, connecting above and below.
And then give heparin before clamping.
Yes, systemic heparin bolus, then place the clamps.
Clamp placement seems critical, avoiding crushing plaque.
Very critical. Use imaging like non-contrast CT if available to see calcium. Palpate carefully. Try to clamp soft against hard plaque, maybe anterior-posterior clamping.
Use atraumatic clamps, clamp aorta first.
Usually, proximal or distal least diseased spot first. Distal clamp often near the IMA, proximal just below the renals if possible.
And if doing an end-to-end anastomosis.
Transect the aorta below the proximal clamp, oversew the distal end. Often remove that short aortic cuff for better exposure.
Clean out the inside of the proximal stump, thromboendarterectomy.
Guys, remove clot, calcified plaque. Helps with suturing, ensures a patent connection. Might need brief suprarenal control to flush debris.
What if the blockage goes right up to the renals?
Control the renal arteries first. Then thrombectomize the infrarenal cuff without an infrarenal clamp initially to avoid pushing clot up. Flush it out, then clamp infrarenally.
Okay, aorta prepped, graft selection. What kind do you use?
Usually a bifurcated knitted polyester graft, Dacron. Good handling, durable, decent pseudo-intima forms. PTFE is another option.
Sizing is important.
Crucial. Size the limbs to the outflow vessels. Oversizing leads to sluggish flow, thrombosis risk. Typical sizes vary, male versus female.
Right. Now the anastomosis. Connecting graft to aorta, end to end versus end to side.
Both work well. Choice depends on the situation. Surgeon preference.
Arguments for end to end.
Proponents say better clean out of the stump, more inline flow, maybe less turbulence, lower pseudoaneurysm risk, maybe better long-term patency.
And maybe lower emboli risk when releasing clamps.
Potentially, yes, compared to end to side where you release flow back into the native distal aorta. Also, lies flatter might help retroperitoneal closure.
And end to side advantages.
Good if you need to preserve pelvic perfusion via patent internal iliacs. Keeps retrograde flow going.
So it helps avoid buttock claudication, ED, maybe spinal issues?
Potentially. Also easier to preserve a large IMA or accessory renal artery, though you can reimplant those onto an end-to-end graft.
How are they actually sewn?
End-to-end. Shorten the graft body, running suture, maybe 3O polypropylene, end to side. Longitudinal aortotomy, beveled graft end, running suture. Need good back bleeding before restoring flow.
Avoid side-biting clamps for end to side.
Generally preferred, yeah. They can crush the wall, hinder cleaning and suturing. End-to-end often recommended for aneurysms or total occlusion up to the renals.
And the distal connections. Graft limbs to femoral arteries.
Pass the limbs through the tunnels, no kinks. Control the femoral vessels. Often extend the arteriotomy onto the profunda origin profundoplasty.
Sewn end to side again.
Yes, beveled anastomosis, maybe 5-0 polypropylene. Flush retrograde and antegrade before completing. Warn anesthesia before clamp release BP will drop.
Then closure. Check perfusion first.
Absolutely. Check pulses, Doppler signals distally, foot appearance. If all good, maybe reverse heparin with protamine for hemostasis.
Irrigate. Close the retroperitoneum over the graft if possible.
Yes, cover the proximal anastomosis. If you can't get good tissue cover, use omentum to wrap the graft, separate it from bowel.
Then close groins in layers.
Copious irrigation, careful layered closure with absorbable sutures.
Okay, let's circle back to that adjunctive profundoplasty. You said it's key for long-term patency.
It really is. The profunda femoris artery, the deep femoral, is so important for leg circulation, especially if the main superficial femoral artery, SFA, is blocked.
And it's often less diseased than the SFA.
Often, yes. Disease might just be at the origin. It provides crucial collateral connections down the leg. Sometimes it's the only pathway.
Though maybe more diffuse disease in some diabetics?
Can be, yes. But its value, especially with SFA occlusion, has been known for decades.
So doing a profundoplasty with the ABFB improves outflow.
Significantly, especially if the SFA is blocked. Some argue for doing it almost routinely in that setting, even without obvious severe stenosis at the profunda origin.
A functional stenosis argument.
Kind of. Common practice is at least to extend the hood of the graft anastomosis over the profunda origin to maximize outflow if the SFA is bad.
And if there's definite plaque there. Endarterectomy or patch?
Almost always indicated then, yeah. Clean out the orifice.
How do you do it technically?
Expose the profunda, carefully preserve branches, palpate to feel the plaque extent, inspect the orifice via the common femoral incision.
Dissect along it as needed, ligate that circumflex vein.
Usually, perform the endarterectomy. If it's extensive, might close with a patch, often vein or pericardium, then attach the bypass graft to the patch.
Or the graft can attach directly if it's just endarterectomy.
Right, and if you're doing a further bypass lower down, it can originate from the patch, the graft limb, or the native profunda distal to the ABFB anastomosis.
What about ending the bypass higher up, at the external iliac level? You mentioned that was done historically.
It was. But we found extending to the femoral level is often technically easier and, more importantly, gives better long-term graft patency.
Infection risk isn't significantly higher with the groin dissection.
Not with meticulous technique and modern practices. But aortoiliac bypass still has a role.
When?
Hospital groins previous surgery, radiation, or maybe obese diabetic patients with bad skin folds, if their external iliacs are healthy, avoids groin wound issues.
Okay. Multi-level disease blockages above and below. Sounds tricky. Treat outflow at the same time. Or stage it.
It's a tough call. Data is mixed on whether a blocked SFA impacts ABFB patency long-term. Some studies say yes, some no.
But if the profunda is bad and the SFA is blocked,
then you probably need an infranguinal bypass too for graft patency and foot perfusion.
does diabetes change the equation much?
One study suggested diabetic patients with multi-level disease weren't more likely to need later leg bypass after inflow repair than non-diabetics.
And symptom relief. Can inflow alone be enough?
Often, yes. Maybe 80% with claudication improves significantly with just ABFB. But some studies show up to 2/3 might still have some claudication.
So no hard rule. Depends on ischemia severity.
Pretty much. Significant tissue loss almost always means you need to address both inflow and outflow, likely concurrently, for limb salvage.
What about fixing kidney or gut artery blockages at the same time as the aortic surgery?
I think
Has complexity, right?
Major complexity. Increases operative time, risk. It's a very individualized decision.
When might you do simultaneous renal repair?
Definitely if severe hypertension is refractory to meds or ischemic nephropathy with potentially reversible function. Also if accessory renals come off the diseased aortic segment.
More controversial if the renal stenosis isn't clearly causing problems.
Very. Aggressive approach argues fix it now, prevent future issues. Conservative approach says added risk may not be worth it. Mortality is higher for combined procedures.
How do you usually fix the renal artery?
Most common is a bypass from the aortic graft using vein or prosthetic. Sometimes endarterectomy or reimplantation.
And mesenteric arteries.
Usually preserving the IMA is enough, especially with an end-to-side proximal anastomosis. Rarely needs simultaneous celiac SMA repair. Staged endo or open repair is another option sometimes.
And if the patient has an AAA and AIOD?
Standard AAA repair is often tube or aortobiliac graft. If AIOD is also significant, might need ABFB instead.
Does that increase risks significantly?
It's more complex, yes. Some studies show higher morbidity like kidney issues, groin wounds, more reinterventions with ABFB for combined disease.
But maybe not higher mortality.
Short-term mortality often similar. Long-term survival might be lower, but that seems related more to the patient's overall condition, age, comorbidities, than the type of repair itself.
So ABFB is justified in selected aneurysm patients with AIOD.
Yes, with appropriate selection. They are a more complex group overall.
Briefly, the retroperitoneal approach, accessing from the side back. Any advantages for occlusive disease?
It's an alternative. Favored by some, especially with prior abdominal surgeries, stomas, need for suprarenal exposure, or maybe severe cardiopulmonary disease.
But benefits like less lung bell issues aren't proven.
Not consistently supported. And clear disadvantage is accessing the right side right renal, iliac, groin, especially in obese patients.
Lastly, minimally invasive. Laparoscopic or robotic ABFB. Where are we with that?
There's interest. Small case series exist, hand-assisted, totally laparoscopic, robotic, different techniques.
Potential benefits, less pain, shorter stay.
Those are the hopes. Reduce complications, maybe cost, quality of life, but balanced against longer op times, lack of long-term durability data.
And it hasn't really taken off widely.
Limited training exposure, technical difficulties, steep learning curve, and fewer indications now because of endovascular success all limit its popularity.
How do outcomes compare to open so far?
Morbidity mortality seem to be approaching open levels, maybe fewer GI pulmonary issues, fewer hernious adhesions. Conversion rates can be up to 20% in some series. Long-term patency still needs study, but intermediate results look okay.
Okay, huge amount on techniques. Let's talk results. How well do these procedures work, short and long term?
Generally, outcomes are excellent, especially in recent series.
There's endarterectomy, localized disease.
Yeah, 5-year patency around 95%, 10-year maybe 85-90%. Operative mortality way down, maybe 1% recently.
ABFB mortality.
Meta-analyses showed around 4.4% 30-day mortality historically. Recent single centers report closer to 1%, comparable to elective AAA repair.
Predictors of higher risk.
Older age, chronic lung disease, low-volume hospital.
Long-term ABFB patency.
Very good. 5-year primary patency, 85-90%, 10-year, 75-85%.
Age matters here too. Lower patency in younger patients.
Significantly. Under 50, 5-year primary patency might only be 66% versus 95% for over 60s. Why? Maybe more aggressive disease, not totally clear.
Gender, SFA occlusion. Do they impact ABFB patency?
Data is inconsistent on gender. Conflicting results on SFA occlusion impact whether simultaneous outflow helps late patency, but profundoplasty benefit, unambiguous.
Approach doesn't matter much. Transperitoneal versus retro, endo versus side, claudication versus CLTI.
No major differences in durability reported based on those factors. And one study comparing endo versus open ABFB found similar 3-year patency and limb salvage.
Symptom relief. Patient satisfaction.
Excellent relief if disease is limited to AI segment. Less dramatic maybe with multi-level disease. Patient satisfaction generally high, over 80% at 5 years in one study.
Survival.
Can be lower long-term, maybe 50% at 10 years with diffuse disease. But near normal life expectancy if disease is localized AIOD compared to peers.
So ABSB still holds up remarkably well.
It does. Although, there's some debate. One meta-analysis suggested patency rates might have decreased slightly over recent decades.
Why might that be?
Hypothesis is, tougher cases now going to open surgery. Redos, suprarenal clamps, visceral work, outflow needed, and maybe less experience among newer surgeons trained in the endo era.
Any evidence for that?
Some studies show higher mortality, lower patency for ABFB, specifically for chronic occlusion.
Right.
Our own institutional review showed the patients are more complex now.
More CLTI, more profundoplasties needed, more failed endo first.
Exactly. Our mortality stayed low, 1%. But 5-year patency rates were a bit lower, primary 82%, secondary 90%.
What factors seemed linked to that?
Multivariate analysis pointed to younger age, prior AI procedures, smaller grafts used more recently, but limb salvage remained excellent, 98% at 5 years.
So the bottom line.
ABFB remains a critically important tool despite endo's proliferation, still highly effective.
What about early complications after these big surgeries? How common are they?
Overall morbidity reported between 17% and 32%. Cardiac issues are the most common cause of perioperative death, hemodynamic stress, fluid shifts.
Lungs?
Pulmonary complications common too, especially elderly, COPD, smokers, poor nutrition. Acute renal failure is relatively uncommon with normal pre-op function, even with suprarenal clamping. Good hydration helps. Meds like mannitol benefit less clear.
Ureteral injury. Spinal cord ischemia.
Ureteral injury usually avoidable with care. Spinal cord ischemia is rare, maybe 0.3%, but devastating. Prevention involves preserving pelvic flow, gentle technique, avoiding low BP. Less of an issue than with early endarterectomy. Post-op hemorrhage after ABFB, maybe 1-2%. Better anticoagulation management, better grafts. Suture line bleeding, usually fixable. Maybe use sealants for oozing.
Intestinal ischemia. Bowel problems.
Weir, maybe 2%, usually rectosigmoid colon. Multifactorial loss of blood supply, low BP emboli. If IMA sacrifice during end-to-end, might reimplant it. High suspicion post-op is key to avoid perforation.
And late complications. Things that show up down the road.
Most common is graft limb thrombosis, clotting in the graft.
How often?
Can be up to 30% with long follow-up, like 10+ years, usually unilateral limb thrombosis.
Does.
Often intimal hyperplasia at the distal anastomosis or progression of outflow disease further down.
Can it be fixed?
Often flow can be restored with thrombectomy catheters. Might need distal revision, profundoplasty, or graft extension. If inflow can't be restored, maybe need fem-fem or ax-fem.
What about false aneurysms? Pseudoaneurysms?
Less common now, but still happen, maybe 1% late. Weakening of the suture line. Tension, technique, wall weakness, infection all play a role.
Where do they occur?
Femoral anastomosis, most common presence as groin bulge. Proximal ones often found incidentally or rupture. Repair usually recommended if they get big due to risk.
Are repaired.
Traditionally, open repair with interposition graft. Increasingly, stent grafts used for aortic ones.
Graft infection.
Feared complication. High morbidity mortality. Diagnosed with suspicion, CT, scans. Groin most common site. Prevention is key sterile technique, antibiotics. Usually requires graft excision.
And aortoenteric fistula. Graft eroding into the bowel.
Rare but potentially lethal, usually proximal suture line into duodenum. Diagnosis is tough. Classic triad often absent. Might have a small herald bleed first.
Treatment.
Similar to infection, usually extra anatomic bypass, graft removal, bowel repair. Good tissue coverage between graft and bowel at initial surgery is crucial prevention.
Okay, one last area. Isolated profundoplasty. Doing just that procedure on its own.
Yes. We've really come to appreciate the profunda's role. It's often spared, even with severe AIOD or SFA disease often just at the origin.
Critical for collateral flow.
Absolutely. Can be the main conduit in some cases, so fixing just the profunda can sometimes be enough.
When might you do it isolated?
Maybe when infected leg grafts need removal, or failed bypasses with no good vein left for redo could help heal a BKA when distal bypass isn't possible.
Best conditions for it.
Need good inflow to the profunda and good runoff from the profunda beyond the blockage. Technique is, as we discussed before.
Risks.
Outcomes.
Low mortality morbidity. Main issues are groin stuff like lymphatic leaks, limb salvage around 75% at 3 years for critical ischemia, patency maybe 88% at 5 years if done for claudication.
Well, that was an incredibly thorough deep dive into direct operative reconstruction for AIOD. So much detail there.
It's a complex field.
Yeah, it's clear that while endovascular is often first line now, open surgery, especially ABFB, is still absolutely essential.
For complex cases, endofailures, yeah. And it offers really excellent long-term results.
Especially with things like profundoplasty. And endarterectomy has its niche, too. Right. It really boils down to a tailored approach. Patient factors, disease extent, other conditions, all matter.
Definitely requires careful thought for each person.
So here's a thought to leave you with. We see constant progress, right? Both endovascular and open techniques keep evolving. We learn more about long-term outcomes.
Yeah.
How might the pendulum swing in the future for AIOD? Will we see open surgery make a comeback for certain patient types? Or will endo just continue to expand its dominance?
Interesting question. Something for us all to watch.